We're going to talk about retinopathy of prematurity. So level set me on retinopathy of prematurity. How many of you have ever done an ROP exam? So about half? That's a yes. So 1, 2, 3. How many have not? 2 have not. And who does the ROP now in 2024?
In that case, it's Belia, Bassett, and Dr.
Belia, Bassett, and so all 3 of them are retina docs?
Dr. Bassett is
Does peds vitrectomy or peds muscles? Peds muscles, okay. And who treats?
Bassett, I'm sorry, Ruby and Belia.
Ruby and retina docs treat, okay. Do they treat with laser or injections or both? Well, which one more often? Have you guys ever seen a injection in a baby eye? No, yes, yes. How about laser for a baby eye? Yes, yes. Have you done it?
You let me do a little bit of one.
That was the only one you ever saw?
One I've ever done.
I knew you saw one, yeah, okay. So you saw one laser, you did a couple of spots, okay? And you've seen a laser for baby eye?
I've done it.
You've done it? Yeah. So you have both done a little bit of and you did that at all children's or here?
Both.
Both.
With Dr. Hess and Dr. Bolito.
Okay, very good. So that's good. That's very helpful level. So most of you have some experience with ROP, which is good. ROP is something 99% of practicing ophthalmologists do not practice in the real world. For a variety of reasons, similar to muscle surgery or LASIK. Any of these subspecialties are not done by most ophthalmologists. But ROP is extremely not frequently done. However, it's extraordinarily testable. Number one, that's why it's very, very important that you learn at least 2 absolute facts about ROP that you don't have to look up, which I'll give you the answer to in the slides. And the second reason it's so important, because I think there's more utility, like vision years in ROP laser than any other procedure that I can think of. The years of vision saved in ROP laser is profound. You'll say I have a great AMD drug. We do a lot of clinical trials and drug development stuff, and I have a great AMD drug. It kills it with AMD. It saved on average 8 or 9 years of vision because these patients are elderly. And ROP laser can save 90 years of vision. It's amazing. It's a really cool procedure, and it's got an extraordinarily high value medically and socio-medically. So next time you're annoyed that you're going to do an ROP exam, remember it's a really nice procedure. Is this?
Should advance. Click on it and then try advance.
Click on it, and I see, click with the button and then try advance.
All right, that might not advance. Let me see, this
May not
will
advance.
Do you want to do, this will, let me see, let me try one.
Here, if you have a trick.
Reverse. This is the control layer.
Oh, so maybe if I pointed it, let me see. Yeah, that's better. Okay, all right.
Okay.
So this is so ROPs, okay, 3 facts about ROP. I just raised it by 1 fact. You have 3 parts to the definition. Do any of you guys know the parts to the definition? So what are they?
It's the zone,
Mhm.
so location.
Location, yep.
The extent.
Extent, yep.
And severity.
And severity, yes, location, extent, severity. And top right is the picture of the location, zone 1, zone 2, zone 3. Zone 1 is a circle around the optic nerve. Can't remember exactly how many diameters in radius it is, but it's a circle around the optic nerve. Zone 2 is a circle around the circle that has its nasal border at the ora serrata. So you know how big that circle is. It can vary slightly, probably, but not much. And zone 3 is everything temporal to that circle. So location, extent, and severity. Location is expressed in zone 1, 2, 3, typically Roman numerals. Extent is expressed in what?
Clock hours.
Yes, clock hours. And severity is expressed in what? Yes, well, no, not quite. Plus, we'll get to doing that next. Close. One more thing. State, correct. Typically in Arabic numerals. So you have Roman numeral, and then you have clock hours. Good morning. And then you have Arabic numerals. Location, extent, severity. And then you have this kind of more subjective call of plus disease, like Kim said. You have what is plus disease? Plus disease is, you have to know it when you see it, and I'll show you some examples. It's basically twistiness and tortuosity of the vessels. Do you guys have a rec cam here? No, we don't have one in all children's either, so no rec cams, okay, because you can always look at pictures and kind of assess whether or not they're plus disease. Reed's here, by bicycle.
You talking about-
Did you bicycle? Did you bicycle over?
Yeah, 4 miles.
Very nice, well done.
Nice to see you. Good morning.
Good morning.
Nice to have you, so.
Did you do ROP laser and stuff?
Yeah,
you
I covered all children's blogs.
Yeah. So location, extent, severity, very, very important that you take that home. And then plus disease is this fourth sort of metric, which is much less of an object of call, especially if you don't have a rec cam, to be able to compare your pictures to standard photos of plus disease. The pathophysiology of ROP is similar to diabetic retinopathy, proliferative diabetic retinopathy. It's basically vessels that grow inwards from the retina into the vitreous and create tractional retinal detachments if they advance. The most important thing about ROP is follow-up, and we'll get back to that again. I'm gonna beat the follow-up drum on this. Good morning. Yes. For a little bit. Okay, what was the first treatment for ROP? First treatment for ROP was let the babies die, because we didn't have ROP until we developed the modern NICU. And ROP is a problem created by medicine, successful medicine, so it's an interesting disease. We've probably done that in other fields, but I don't know exactly which ones. But in ophthalmology,
Macular degeneration.
macular degeneration, we all live too long, live too.
I think it was first described by Chandler and Grant. They covered all children's. And oxygen,
Yeah.
about the time I was born, oxygen became available in hospitals. And, you know, oxygen's good for you, so they gave it to all the babies. And I remember my mother, and my mother had heard about it, you know, she's just she had heard about it, and when she had me, she said, "Don't you give him oxygen." And that explains a lot about my.
Your excellent vision, about your
They
excellent.
put like a
vision.
sock over your mouth, you know, his mother was insistent.
But they described it not as ROP, they described it as.
Retrolental
lentil
fibroplasia, yeah.
Because the retina would detach, and you had this membrane behind the lentis,
Yeah.
but it was
Yeah.
fibrotic.
So
And
they didn't see
and-
it before it had detached and
they-
become like a closed funnel.
And Chandler and Grant were the glaucoma experts, and when this thing occurred, it drove the pressure into the 50s. So they were called in and they described it.
That's interesting.
That's interesting that they were glaucoma people, and that makes sense that the patients would have these hard red eyes with this retrolental fibroplasia and super shallow chambers. Really interesting. So if you want to take a historical perspective, you can Google these photos of blind kids in class, because there was basically a very short epidemic of blind preemies, you know, from ROP, who were born in the 1950s, right? Is that 50s?
I was born in 46.
Yeah, so late 40s, early
Yeah,
50s.
Yeah, I was born in the Boston Lying Inn,
Mm-hmm.
and when I went to medical school, my dorm was right across the street, which is kind of neat. The other thing about the Boston Lying Inn is the doctors there, after Pasteur got going with his germ theory in the 1850s or 1860s, they wouldn't wash their hands. They didn't believe in it. And so they had a very high maternal mortality. But the midwives in Boston did. They
Wash
washed
their
their hands.
hands, yeah.
And as a consequence, people stopped going to the hospital to have babies. But so it shows, you know, another one of Harvard's great contributions.
So this is a bad disease, as Dr. Pavin is saying, it's a bad disease. The end stage of it is closed funnel retinal detachment. So we forget we have a lot of bad diseases out there, like proliferative diabetic retinopathy and wet macular degeneration are really bad diseases of you know, middle age and then aging, and we forget how bad they are. This was a really terrible disease. So there was intervention developed in the 1980s for this, which was cryopexy, and that was determined to be effective in a large randomized controlled trial with almost 10,000 infants. We don't do 10,000 person studies in ophthalmology anymore. That 10,000 was cut down to about 300 that developed the definition of threshold ROP, which we're going to go over because of this trial. And half of them were randomized to cryo, and half of them, they did nothing and just let them progress. They were truly untreated controls. And the primary outcome was unfavorable structural outcome, meaning basically inoperable retinal detachment. And if you look at the results of the trial, we'll talk about what we were tolerant of in that era. So this is a classic drawing of what threshold is. This is the second thing you need to remember. You should photograph this in your mind, or remember to Google it before the boards. This is extremely testable. This is the old definition, kind of the classic definition of ROP that you treat. It's 5 contiguous or 8 non-contiguous clock hours of stage 3 in zones 1 to 2 in the presence of plus disease. Remember, it has severity, extent, and location in it. So if you remember your severity, extent, and location, then you'll get it right. Let's all say it together one time. Ready? 1, 2, 3. 5 contiguous or 8 non-contiguous clock hours of stage 3 ROP in zone 1 to 2 in the presence of plus disease. What's important about that is you don't have to really memorize it. You have to understand it. You know, you have to, if you it's only teaching someone to fish things. So you can think in any terms you want. I take it backwards, like a location. So zone 1 to 2 is bad. So remember zone 1 to 2. So what's threshold? You say zone 1 to 2, and then you think about, so it's location, extent, and severity. How many clock hours? 5 contiguous or 8 non-contiguous. You can remember that because it's not quite half if it's contiguous, but it's more than half if it's non-contiguous. So not quite half to more than half. So 5 contiguous, 8 non-contiguous. And what stage is it? You have to know your stages to think of this. Stage 1 is basically a line. Stage 2 is an elevated line. Stage 3 is neovascularization. You should never have to think past stage 3 unless you're treating and perhaps operating on ROP. So just think up to stage 3. So stage 3 is neovascularization. So 1 to 2, 5 to 8, stage 3, plus disease. You have to remember to say plus disease. For me, that's the easiest one to forget because it's kind of a soft call, but plus disease means twistiness of the posterior vessels. And I'll show you photos in a moment. But the vessels that get wiggly in the back, I remember, I think Bruce Hess told me, or maybe you told me, somebody told me that in the old days of screening ROP, the docs would just come and just look, because the only criteria you needed to treat was plus disease. And if it didn't have plus disease, didn't merit treatment. So you don't have to look at the periphery, you just look at the posterior pole. And if it's very twisty, then there's problems in the periphery also. So that made it's a lot easier than looking at the periphery if you have you said a couple you examined. Have you examined ROP, baby?
Yeah, a little bit.
Yeah, it's hard, right?
Yeah, very hard.
They're wiggly and they're tough to see. It gets a lot easier. They're my easiest patients. They don't talk to me, which is their best feature. And their parents don't talk to me because their parents are not there 90% of the time. Kind of sad, but it is what it
So
is.
have you defined the zones yet?
Oh, the zone. Yeah, we did zones. Yeah.
Okay.
Did you want to comment on zones?
I once killed a patient,
Yeah.
because they just gotten the new nice NICU rooms.
Yeah.
And the nurse thought I knew what I was doing, but I didn't, and he got bradycardic and arrested. And they escorted me from the room, but when I went back, a couple of weeks later, he wasn't there.
During the exam?
Well, he might have done. Because bradycardia comes back from the pushing.
He arrested. They called a
Yeah,
code on it.
You might have
And
just spent
everyone
time.
came running, but they thought I was, because I was a doctor, I knew what I was doing. I'm a dumb ophthalmologist. I didn't have it.
Yes.
I didn't have enough brains to stop, and it's a real threat.
So
So
yeah.
just examining the kids,
Mhm.
he's gonna tell you now about the intervals.
Yeah. Oh, the
You
interval.
don't, you don't randomly say, oh, I'll just examine them for fun, just to make sure.
Yeah, so
Uh-uh.
their criteria, the criteria are hospital by hospital, but basically they're sick infants. They're less than 1,251 grams, or they're under 31 weeks of birth, or there's other combinations of things. But the hospitals all make up their own criteria for calling the consult. And then, but the follow-up's really easy because it's binary. You either follow them up in 1 week if there's any ROP, or 2 weeks if there's what we call stage 0 or no ROP. It's pretty easy to determine your follow-up intervals. You don't have to think about it a lot, which is great. If you're seeing a lot of these patients less often than every 2 weeks, like every 3 or 4 weeks, you're probably not seeing them often enough.
I'd stretch it out to 3 or 4.
3 or 4?
Yeah,
What
I don't-
age though?
I can't remember the criteria, I mean,
Yeah.
I don't know if I had breakfast this morning, I can't remember that.
What
So don't ask
what
me.
age do you start stretching them out? When they're older?
Well, no, if they have almost no disease,
Yeah, so you can't, so that's, 3-week follow-up is reasonable for a baby who's relatively healthy, not on oxygen, no disease. Lots of people
the
do
other
that.
thing they did here is they would always call the consult about 1 or 2 weeks ahead, what is it, 30
Yeah.
weeks?
It's
20?
30, they call them as early as 30, 31 now, yeah,
Well, you can't see in.
Right.
This
Hazy.
vitreous haze.
hazy.
So there you are, torturing the kid, making him bradycardic, maybe a
Yeah.
rest or two, you know, because the nurse doesn't know that you're dumb and
Yeah.
so on and so forth.
So it's never an emergency to see the consult at the beginning. You can always see it within a week. And what I do, so what Dr. Pavin says exactly right. You can't really see it. So a lot of these I start seeing at 31 weeks. So it's kind of a meet and greet because you don't want to kill the kid or, you know, or extubate them or pull out their 17 lines. So what I do at 30, you know, I see a lot of them at like 31 and 4, 31 and 3, whenever they call me, I go in, I look, if I see an optic nerve, I'm done for 2 weeks, we're done. You know, if everything looks structurally there, I tell the nurse it's a meet and greet, it's gonna take me 15 seconds per eye. We're working around their non-invasive CPAP, you know, it looks like they're like about to go scuba diving, you know, you don't have to see the periphery at that stage. What age are the kids most likely to develop threshold ROP? What is the age at which most kids were treated in the ETDRS, the ROP study, which is coming, more modern study? How many weeks adjusted gestational age?
Is it the 31 to 33 or?
No, that's when you start seeing them, it's when you get the consult, usually it's 31 to 33.
You virtual people can answer too, if you're there.
Yeah, you can even look it up, we wouldn't know.
Yeah. It's 36 to 38 weeks adjusted gestational age, so you have time for the disease to develop, you know, don't think you're very likely to miss treatable disease in a 32-weeker, it's highly unlikely. But you gotta be able to see clearly with a good dilation in a high-risk kid by the time they're 35, 36, 37 weeks.
And just really quick, there's a
Yeah.
mnemonic for this, it's 1 + 2 is 3 + 5 is 8.
So to explain that to me, tell me what that is.
1 + 2, so there are a bunch of pluses in there to remind you that it has pluses.
That's good, that's good.
And then, 1 and 2 are the zones, 3 is the stage, and then 5, you know, contiguous or 8 non-contiguous
1 + 2 is 3 + 5 is 8.
You just have to
plus-
remember
oh,
the one and
That's a great mnemonic. I love that mnemonic. That mnemonic postdates me learning about this. You just look it up.
No, Dr. Rufi taught me that. on-
Good. Dr. Rufi gets a gold star for remembering or coming up with that mnemonic. It should be the Rufi mnemonic. Fantastic.
I like that.
Is Mamta still here?
She's currently in OR.
No, yeah, because so I'm sharing a patient with her, which is cool. Yeah, okay. Anyway, 1 + 2 is 3 + 5 is 8. That's great for your boards. I love that. I love every bit of that.
You mentioned the vitreous is hazy, like less than 30 weeks. Is that
Yeah.
the case for healthy kids as well?
Yeah, all kids, well, there are no healthy kids who were born at 30 weeks. That's
Yeah.
kind of a false choice.
There you go.
But the
Sometimes
vitreous
another arrow
is
is on.
hazy in all the kids, thank you. Also, they have tunica vasculosa lentis, their lenses are hazy because their lens is vascular, that's a part of it too. And the vitreous is hazy, it's hard to see things, but I've never had a child that I've started with ever progress to need surgery, so you can catch 100% of them. I have 100% success rate in not having a kid that I started seeing ever go to vitrectomy for progressive disease, which is good. I did have one kid develop an endophthalmitis who went to surgery following an intravitreal Avastin injection. Interesting story for a time that we're not recording. All right. Sad story, but
Still not an answer.
I think we spent too much time on this slide, which is good. This is probably the most important
This is the
slide of the
arrow
whole.
first. Yeah, I think you pointed to the screen And then advance it. Sometimes that little, the
Oh,
little
I
button
see.
up top,
Up top is the
sometimes, yeah.
wake
sort
it
of
up,
brings
wake it
back
up
to life.
button.
And point this way. Right here. I'll just advance it. when I see
Here.
it's struggling. Okay, got it.
There we go, yeah, I can, let's try it. Okay, so these are the standard photos of plus disease. Twisty vessels, plus, and the mnemonic, remember you have to have plus disease for threshold. Now, you don't,
Is that's not the original photograph in the first cryo ROP study.
that's from ROP, I think it's from the ETROP study, but you're right, it might
It's-
not be
it's-
from ROP.
It's much less plus than the original photo.
Yeah, all right, but this is the outcome of the study. The outcome is we tolerated really bad things. Remember, an unfavorable structural outcome is basically an inoperable retinal detachment. So we saw only a quarter of the patients who got cryo had inoperable retinal detachments. Only 25% had a complete failure to see ever after treatment. But without treatment, almost double, almost half had inoperable retinal detachment. These are terrible outcomes. You know, you see these patients complain that they can't see up close with their multifocal IOL. Well, here you have a study where 1 out of 4 patients treated with a successful treatment that was the gold standard went absolutely NLP blind in both eyes.
Unbelievable.
Unbelievable, right? And of course, the visual acuity outcomes were similar. This was superseded by the ROP study, early treatment for retinopathy of prematurity. And this is important because this is another set of definitions that you need to know. So you need to know how to kind of grade the disease. You need to know your threshold characteristics, which are kind of hand in hand with how you grade the disease. Then you have to know what we consider high-risk pre-threshold criteria, which is now termed type 1 ROP, and threshold is termed type 2 ROP, because you actually treat with type 1 ROP, so you can't just look at the optic nerve anymore, because the criteria do mean you have to at least see the periphery to meet some of them. And it doesn't mean they're all gonna get worse. Look, the definition is that this is a high-risk group. It means only 15% are at risk of progressing without treatment based on how this definition was created. That's a lot better than we did just 20 years before with cryo, 25 years before with cryo. So the things to remember here, stage 1, so with zone 1, like way in the back, with plus disease, and you can see this in these very young kids. Often it's called rush disease if it looks like that. If it's very posterior and you have plus disease, you can get this flat neovascularization. Zone 1, any stage 3, with or without plus disease, and then something that looks more like threshold disease, which is zone 2, stage 2 or 3, with plus disease. So you do have to be able to see the periphery, but remember the periphery in a patient who truly has zone 1 disease is not that peripheral. It's still something you can look at. Do you guys have angiography on little kids here? We don't have that at all children's either, but you can get these glorious photos of patients with pre-threshold or type 1 disease. And this basically made it simple and feasible to treat kids at an earlier stage with laser. Why laser? Because the laser is a lot more benign than the cryo. Remember, a quarter of those kids with cryo with successful treatment still had inoperable retinal detachments. So the laser was a big advance as far as the therapy being more gentle.
Well, the other thing that happened is they stopped giving so much oxygen.
Yeah, that's
You know.
huge. We turned with, they were much better with oxygen titration. That's why we don't have to treat so many kids. Laser looks like this. This is not like your ROP, your PRP at the, you guys still do PRP at the VA probably relatively often. Does it look as dense as the photo on the top, on the left there? Usually not quite that dense. You know, these spots, by the time they grow with laser edema, they should basically be confluent.
Yeah, but those spots, if you put in a laser burn, PRP or this, within about 2 minutes, 3 minutes, they double in size.
Yeah, they grow.
So you're shooting and you think, well, I'm leaving spaces between them, and you're not leaving much.
Yeah.
Yeah, and you treat beyond the proliferation.
Like posterior to the
treat-
proliferation.
You don't treat the ridge.
you treat beyond it, that's the
Yeah, you
avascular
don't,
retina,
you
that's
treat, you
the
treat,
driving force.
right, you don't treat the ridge, you don't really treat posterior to it, you treat anterior to it, you're treating forward. I think the first time I did one of these with you, I started putting spots behind it, cause they're where you see it more easily, you have to really look anteriorly, you know?
The other thing that happens is, when you have zone 1 disease, it's an enormous amount of retina you have to treat. And I had an enthusiastic fellow once, and he treated so much, he caused anterior segment necrosis. And
Very, very tragic,
we
yeah,
got bilateral cataracts.
yeah.
And I went back to see the guy, I couldn't see in, but he had pendulum nystagmus, so I was very upset, but he nearly lost the eyes, he got cataracts, but then we got the cataracts out of there.
Yeah, I had one patient like that, didn't detach, but wound up needing a cataract surgery in one eye, cause the laser was probably too heavy for the fusion, yeah.
But that's the wonderful thing about the Avastin shots.
Yeah, you eliminate.
You buy
that risk.
yourself at least time.
Yes.
And you
yeah.
can, maybe you could stage, do half a retina and wait a couple of weeks to the other.
You can, but there's no data on stage laser, but you can do that, that's true. There's no, the Avastin shots are really interesting, we'll get to them, I employ them. Maybe not the same way that's employed here, but there's not a clear-cut right way to use them. What is clear-cut is they are absolutely revolutionary. The Avastin shots are the reason I have 100% success and never having a kid go to surgery with me. I also never, ever let the kids leave the hospital without laser. They never, for me, they never leave the hospital without laser because they're never coming back. My follow-up rate with this disease in the real world after a year is like 10% on a good year,
The same thing here. A lot of them are lost to follow-up.
like 90% of them.
Do you know why? Because this state is the meanest state in the union. And our Medicaid kids, Medicaid is designed to prevent people from getting care,
Mhm.
and especially these kids. They come in, they see a doctor who's on their programs. They divided the Medicaid kids up into groups. They're on, Plan 13, HMOs. They come back to the same doctor a month later. I'm just talking any doctor. They walk into the office and the doctor says, well, you're on a different plan now. What? I didn't know my plan switched. Yeah, we don't participate in that plan. So for people rendering ROP care, we can't get follow-up. We can't get paid for it. We can't swamp your office with these. And they get lost to follow-up. It is a system design. And the state didn't accept the Medicaid money either. This is a mean state. You have mean politicians here. Don't, and I love the tax structure, but it is a mean state.
Nothing is free. Good tax structure, mean state, Sometimes you get mean tax structure and mean state though.
I won't, you can probably guess how I feel about the politicians,
You could be the next president of the Florida Society of Ophthalmology. I will pass you the baton.
Not a chance. I got a nice chest scar. I don't have a stent. I don't need any more of that.
So I'm currently the president of the Florida Society of Ophthalmology, which is a,
You are?
yeah, which is a,
Oh, God.
they finally got me
You want
into
me to
it.
schedule your bypass?
Well, the Senate is in session right now, so it is very much a political game. But I was very grateful to be president, along with the preceding president, a retina specialist on the East Coast named Joe Nesgoda, when a lady named Kathleen Passidomo was last year and is this year Senate president. Why am I so happy about that? Kathleen Passidomo's father was an esteemed ophthalmologist who passed away last year at 100 years of age.
Wow.
In the Southwest Florida, and I'm grateful that she's my Senate president because we know that she has a bias and a preference towards protection of patients through excellent ophthalmic care.
Great. You got that speech down. Very good.
So give your money to the Florida Society of Ophthalmology. You never know who the next Senate president will be. You do, but just maybe not quite as awesome as Kathleen Passidomo. Okay, so where were we? We were looking at
Laser.
A laser, okay, right, so laser, so, okay, very good. So let's go on to Avastin. This was the first study, kind of there's larger data sets now that I don't have in this deck, but this was the first study that prospectively showed us that the Avastin can be used comparably to laser. It was called the BEAT-ROP study as opposed to the ET-ROP study, which is patients randomized to Avastin versus laser. And there was a retrospective chart review as well. And what we found out, a lot of this is data here for you, there we go, is that if you treated the patients with Avastin, especially if they had something called, this is stuff I don't think you need to know for your boards, but there's something called a VAS, which is a vascular activity score that was graded 0 to 10 retrospectively on the photos. Basically, the take-home message is the Avastin worked as well as the laser in all comers, as far as the primary endpoint of the study, which was not the development of bad anatomic outcomes, but it worked especially well in patients with posterior disease. If they have bad disease, if they have what you think is what they call AP, aggressive posterior rush disease, or that disease in zone 1, basically with all the twisty vessels, the Avastin's better. It lets the vessels mature anteriorly. And as they mature anteriorly, you theoretically get more retina, so you get a better visual field and a healthier eye when the kids are older, and then you do laser. Or you don't do laser, but you can at least buy them time to get better.
So with the Avastin, they still grow their vessels out?
Not always, and never, and that's the thing, is a lot of patients, this is why they never leave the hospital without laser for me. There's a large
They grow
proportion of
some?
patients in this study that stop growing at some
Okay.
point. But if they're super posterior and you have Avastin them, they can grow some.
They grow some, huh?
Yeah, would you agree with that in general? Because this gets to be very soft core. We don't have data on exactly how
I
much of
don't,
this is growing.
it used to be the routine here, give them a shot of Avastin.
And
And then they were gone, we stopped giving laser. And I
Yep.
think that,
They haven't come back yet.
no,
If that's the thing, they never follow up, so we don't know.
That's
And they have,
right.
they leave with all this avascular retina, you know, but they haven't come back. They haven't come
I
back
think
with the red.
most do pretty well.
They most, because otherwise they would be coming back in droves of kids with red tip canes looking for some kind of ophthalmic care. You know, and we just don't see that. So most of them probably do well, but in the real world, we don't know. Which is what makes me so nervous, because we do know from this data that we have a regression pattern study, and we know that when you treat them, the late complications are from persistent peripheral non-perfusion and late fibrovascular proliferation. It's well documented that we do have late fibrovascular proliferation in these kids with poor anterior circulation. What did I write here? This is another supportive, there are several supportive studies, and I have these in here. We're gonna put this on our residence
They
access.
get all the
Yeah.
conferences, actually.
All the conference, and you
The
can look up,
videos
you
of
can
the
look up the data if you need to. But the regression patterns showed that retinal vascular development is stunted without progression until at least several weeks after injection. Everything just stops. And when they did get retinal detachment, the onset was later than the non-Avastin eyes. The onset was at about 52 weeks, not 41 weeks. When do you stop seeing a kid who has peripheral non-perfusion? There's no endpoint to treat to. You don't know when to stop seeing them. You know, you can't bring them in every 2 weeks or 4 weeks forever. Eventually, you have to stop. So, you know,
And they get very hard to examine as they get
as they
bigger.
get to be like
They get
2 or
very
3, yeah.
strong.
Yeah.
It's not trivial.
It gets tricky. It becomes a trickier thing. There we go. See, I know
Stop
if
again.
I know when those little, there we go.
I got
Thank you.
it, I understand.
Yeah, so and the recommendation of these studies that their close follow-up beyond 60 weeks adjusted gestational age is recommended in the literature for these kids, beyond 60 weeks. So, you know, if you do get one of these kids who has anterior non-perfusion and then detaches and then has vision loss, then you're probably in trouble, because there's a lot of literature supporting how you ought to see them more often. Now, another question is, does the Avastin cause the patients to have more developmental delay than we see in patients who don't have Avastin, because it has some systemic exposure, and you know, it's a time of life where you're supposed to be developing all your what happens in your baby? Prefrontal cortex associations, who knows? Stuff good.
Long time.
Your things happen in your brain when you're small, because you grow up and become an ophthalmologist, so those things have to keep happening. So does the Avastin stop them from happening more than these brains are already kind of cooked in these preemie babies, and they're unlikely to be ophthalmologists already? Well, there's good data from the ROP study that's now over 10 years old, that there's not a difference in the rate of developmental delay or the severity of developmental delay in patients who are treated with Avastin and those who weren't. That's pretty much put to bed now, which is good. And remember, these are very, very low doses. And this is a retrospective study looking at 2 different doses, not 50 cc's, but 30 cc's of, they're not 50 microliters, but 30 microliters of Avastin. When I treat these kids with Avastin, I push it down to the 50 microliter mark, and then I try to push out half of that. So I'm trying to treat with 20 to 30 microliters of Avastin. And there is an FDA-approved drug for ROP now. What drug is that in the US?
No idea.
Aflibercept, Eylea. Eylea is on label for ROP. Why did Eylea go through the expense of a study to put their drug, their multi-billion-dollar drug? At 1 year, it was the 4th largest Medicare expense of all the drugs, on label for ROP. As a drug developer, it's a great trick.
Oh, is it the compassionate use?
No, it's not compassionate, it's on label. It extended.
No, is it the?
Extended the patent.
Extended the patent.
Oh,
It
okay.
extended the patent by 6 months.
Oh, I thought it was that thing, you get that voucher.
Hey, so think about,
Don't
so
work.
they invested in a study, and it's a better drug, it's in prefilled syringes, it's not, I would not have had my 1 case of post-injection endophthalmitis if there wasn't a contaminant possibly inside the hospital generated Avastin syringe. It's better, but is that why Eylea went through probably the $50 to $100 million to put this small study together?
Did you just hear what he said? It's about 50 million to do any study. It's just.
And this was a small
Drug
study,
development.
mostly ex-US, small study, lower prices, fewer patients, and it,
Just the new drug applications over. $1 million.
Yeah, so-
Just applying to the.
so why did they do that? They did it, I mean, sure, it's a good thing, and you can argue that it's a good thing, but they also did it because you saw a lot more than $50 to $100 million of Eylea in 6 months, without even thinking about the patent battle. And then Aflibercept, Eylea just won a patent battle. You can Google the outcome of the case. It was about 2 weeks ago. There are multiple Eylea biosimilars ready to launch, and they theoretically could have launched in June of 24, meaning in 3 months, but not now, because there was something in the Eylea patent that was supported in the US patent courts, which has stalled the biosimilar launch. The end date, the patent expires in 2027. But that's 3 more years of on-label 2 milligram Eylea. 3 more years to convert them all to 8 milligram Eylea.
I know, yeah, you get the patent longer.
And then that's a whole new,
Who's the company?
Regeneron.
And they're still independent. They didn't get.
No,
bought out.
Regeneron's a publicly traded, independent company
Yeah, Genentech, of course.
with Roche,
Roche Tech, yeah.
Anyway, very interesting. The drug development business is kind of fun. Good for people, good for everyone at the end of the day.
You wanna go farther?
Yeah, let's go farther. Let's see, I'm getting close to the end, because this is all stuff that I want to put in the deck, but not stuff that you necessarily need to know. But there's lots of evidence in here that patients do not develop developmental delay, do not get sick, do not die on Avastin, but it does not necessarily cure the disease in the way that laser does. Let's see. I think that's pretty much my whole talk. This is just more supportive data for you comparing laser to ROP. Any questions about ROP or things you need to know? What are the 3 things you need to know?
Threshold
That's
variation,
Great. Threshold, yep.
how to classify
How
it.
to classify it, and one more thing. Definition of pre-threshold, type 1 ROP. Those 3, if you get those 3 things, you'll get it right in clinical.